Hey guys, it's Matthew Zachary, and I want to tell you about the National Comprehensive Cancer Network, or the NCCN. The NCCN creates the treatment guidelines for doctors that help cancer patients lead better lives. But I want you to know that the NCCN also has guidelines for you. The patient guidelines were funded by the NCCN Foundation and were created just for people with cancer and their caregivers. They're free, they're easy to understand, and they're available right now for you, the patient and the caregiver. So go check them out at nccn.org/empower. That's nccn.org/empower.
My favorite thing about working in healthcare is the people. This industry brings together brilliant, highly motivated individuals who are driven by the opportunity to make a difference. My name is Hallie Tecco, and this is The Heart of Healthcare, a podcast where I'll be introducing you to the people on the ground moving the needle in public health and medicine. While LGBTQ Americans share many of the same health concerns as the general population, like affordability and access to care, they also face unique challenges that impact their ability to live healthy and affirm lives. In fact, LGBTQ people face worse health outcomes, including a higher prevalence of anxiety, depression, suicide, substance use disorders, eating disorders, obesity, heart disease, and even some cancers. Understanding these health disparities starts with understanding the history of oppression and discrimination that these communities have faced. But largely, we have failed to connect the dots here. Sexual orientation and gender identity questions are not collected on most health studies or government surveys, making it quite difficult to estimate and understand the health needs. But that's changing. Today, I'm talking to a doctor and researcher who has dedicated his life to serving these communities. Dr. Mitchell Lunn is an openly gay physician and researcher at Stanford University in the field of sexual and gender minority populations, also known as SGM. He is the co-director of PrideNet, a participant-powered research network of SGM people that engages communities at all stages of the biomedical research process. He earned his MD from Stanford and his master's in advanced studies degree in clinical research from the University of California, San Francisco. He completed his internal medicine internship and residency training at Brigham and Women's Hospital and a nephrology fellowship at UCSF. Dr. Lunn, thank you for being here.
I am delighted to be here. Thanks for inviting me.
Let's start with a question I think a lot of people have, which is why and how does sexual orientation and gender orientation impact health outcomes?
Yeah, that's a great question. And I think this is one that many people, as you pointed out, think about and wonder about. And there's actually several hypotheses about this, but one leading theory is the concept of minority stress. And this model is actually made up of several components that include experiences of stigma and discrimination in society, such that people even become trained or ingrained to start to expect these negative experiences. And this, of course, also can be accompanied with what we sometimes call internalized homophobia or internalized transphobia. So this is actually, the experiences of shame or feeling that you're to blame for your own sexual orientation and gender identity. This then results in downstream effects that include mental health outcomes like anxiety, depression. It can also result in some negative coping behaviors, things like substance abuse. And similarly, this also affects people's presentation to healthcare, that they may not go to the doctor or to the healthcare provider's office because they're afraid of those negative experiences. They're afraid of being stigmatized and discriminated against in the healthcare system and those interactions. And so it's not really sexual orientation and gender identity that cause the health problems. It's society's influences on people who are LGBTQ+, and that results in in many of the health disparities that we see in the community.
So on the note of discrimination, the research shows that 55% of lesbian and gay patients and 70% of transgender patients feel that they have received discrimination, substandard care. Tell us more about this stat and what can we tell providers for creating a more welcoming experience?
Yeah, and this I think is a sobering statistic that many that I think those of us in LGBTQ health are really always disappointed to hear and upset to hear, and really I think is a driving force for many of us. And this when I was a medical student back in I started medical school in 2005, and shortly thereafter, me and a group of my colleagues at Stanford started to look at the what's called medical education, how well doctors are trained to care for LGBTQ plus people. And it was a study that we did towards the end of our medical school time, so in 2009, 2010, where we looked at how well medical schools in the United States and Canada train future doctors to care for LGBTQ plus patients. And at that time, there were some, kind of sobering statistics on the number of hours that are taught in medical school, something like 4 hours, and that a third of medical schools, had zero time at all devoted to caring for LGBTQ plus people. And so a large component of this, of why lesbian and gay people, as well as transgender and gender expansive folks, have received substandard care, discrimination. Some are even blamed for their healthcare status in the doctor's office, largely as an educational issue. Again, doctors and healthcare providers, like everybody else, are subject to the same influences, whether positive or negative, that society has had over many decades and centuries. And so part of this is a lack of medical education, and that study that we did now 10 or 11 years ago is being repeated right now. So we're hoping that there's an increase in medical education to healthcare providers to care for LGBTQ plus people. But again, I think that a lot of this is that same concept of minority stress, that same concept of negative influences in society. And, I always emphasize that going to the healthcare provider's office is one of the most it's an extraordinarily vulnerable thing that we do, right? And the healthcare provider has, if you're going to a new doctor, you've never met them before. They ask you a whole bunch of rather personal questions about who you are, who you have sex with, what drugs or substances you use, what medications you take, what your family life is like, what life at home is like, how your kids are doing, all these things in a very short amount of time. Trust has to be built very quickly.
While wearing a piece of paper.
I was just going to say, and then they tell you to take your clothes off. We do it, and then we let them touch us. Yeah. Right? All in like 20 or 30 minutes, right? So
it's so crazy when you say it out loud.
Right? That doesn't happen in very many other industries, right? And so yeah. There's a huge amount of trust that has to be built at the beginning. And so if you have the stats that you mentioned, 55% of lesbian or gay people and 70% of transgender people experiencing poor health care, you can imagine that they're never going to come back to the healthcare provider's office, right? Why would you go to a place that you're going to be discriminated against or feel stigmatized, right? When you can avoid it, right? And so this, of course, results in really delayed presentations of things, right? So not getting your age-appropriate cancer screenings, not getting your pap tests, not getting your mammograms, not getting your colonoscopies, not getting your prostate serum antigen, the PSA test for prostate cancer.
Yeah.
And what happens is we have people showing up, stage 3, stage 4 conditions, or high blood pressure that's been uncontrolled for decades, right? Yeah. Things like that. And so there's really, and so part of this involves, one, educating providers very early, aka medical school, undergrad, middle school, elementary school, about how to be, a welcoming and affirming person to LGBTQ people, and eventually a welcoming and affirming provider, right? And that, I think, will then allow LGBT people to have the healthcare that they deserve.
Within the hospital setting or clinic setting, how do the EMRs kind of fall short? I imagine they don't allow someone to be gender fluid. Um, Tell me about where they fall
Yeah.
short and what
Yeah.
we can do on the EMR side.
On the EMR side, yeah. So the EMR side, the EMRs have advanced, of course, many, and I say this a little cynically and a little bit, it's unfortunate, but I think it's also true, is that, EMRs, I think from many providers' aspects, were meant to be efficient billing machines, right, for hospitals and healthcare systems, to collect information that is needed to bill insurance in the most optimal way for the best reimbursement, right? And so they were not always met and thought about from a patient-centered care perspective from the beginning. So I think that's changing gradually as people are like, we've got the billing down, let's try to make it a little nicer for human beings now. And so a huge percentage of the healthcare system in the United States, I think it's now 60% or maybe even greater, use the electronic health record system made by Epic. And there's a couple other large healthcare, EMR vendors that are, that constitute something like a total of 90 to 95% of the U.S. healthcare system. And many of these vendors have now gradually moved to having the ability to collect sexual orientation, to collect gender identity, to collect the sex that somebody was assigned at birth, such as what's marked on their original birth certificate, and to collect the pronouns that they use. There's a variety of ways that those are handled, right? In some EHR systems, those are listed at the top that this person has this gender identity and uses these pronouns so that they don't get misgendered or have inappropriate care given to them throughout the course of their experience in the healthcare system. And other places that data gets collected and it kind of lives in some hidden screen that you have to, click 1,000 times before you can get to, and nobody ever checks it, much less do they fill it out, right? And so because sexual orientation and gender identity is so infrequently and really inconsistently collected in electronic health record systems, there is a lack of data in the electronic health record systems that exist across this country. And that really limits our ability, especially, as a LGBTQ health researcher, that limits our ability to understand the health disparities that are affecting the LGBTQ plus population.
Yep. Interesting. So you mentioned, that this can lead to people being misgendered. What exactly does that mean, and what is the impact of the patient when that happens?
Yeah, absolutely. So I think the important thing to think about when we think of gender identity is that, gender identity is, includes many things, right? But I like to talk about the definition of a term that people, I think, are starting to become more familiar with, but it is still not known by everybody, and that's the term cisgender, and that's CIS gender, and that's really a term that is used to describe somebody whose gender identity is kind of what is commonly expected or associated with somebody based on their sex assigned at birth. So let's take me, for example. I was assigned male sex at birth. When I was born, the OBGYN or pediatrician said, it's a boy, right? That's typically based on external genitalia, right? Whether you have a penis or a vagina when you're born, and the doctor makes that decision, or the healthcare provider who's delivering, and that ends up on a birth certificate. And my current gender identity is a man. I identify as a man. So most people in our society are cisgender. They identify with a gender identity that's aligned or is most commonly associated with the sex assigned to them at birth. And so we think about cisgender people as being the majority, or we sometimes call them gender majority people. And then everybody else is a gender minority. And so that, of course, includes people who are transgender. So, for example, if I had a gender identity as a woman, but was assigned male sex at birth, I would be considered a transgender woman. Or if I was assigned female sex at birth and I now identify as a man, I would be a transgender man. But there are people who we now know that there are more than two genders than just man and woman. People are non-binary. Some people are gender fluid, as you mentioned. And so it's important for people to be respected, right? And so misgendering somebody is basically assuming that they're a different gender than they are. right? And the part of that's because they haven't been asked, right? So one of the things that I think people are becoming also more familiar with is pronouns, right? So I use he and him pronouns, and if I was more feminine appearing, and that could be the way I look, so that my hair, if I was wearing makeup, if I was wearing more feminine clothes, and somebody addressed me by the wrong pronoun that I use, that would be you constitute being misgendered. So for transgender people who come into, our clinic at Stanford, where we have an LGBTQ health practice, we make sure that we refer to people by the name that they use and by their pronouns, regardless of what sex they were assigned at birth. So, and that's really a way to show that, the healthcare system is welcoming and affirming and values people for who they are and what their identities are. It's really a sign of respect. And the impact on patients when somebody is misgendered is they're less trusting and less respectful of you as a provider, of the healthcare system that they're interacting with, et cetera. And it kind of leads to that same thing that we talked about earlier of being discriminated against or stigmatized or kind of, put on display as being somebody different, that turns people away from the healthcare system and can really have negative effects on their health broadly and their well-being.
Do you think people should always ask for pronouns or only when they don't know?
Yeah, it's a great question. I think we try to normalize pronoun asking for everybody, and there's ways to do that I think is a little bit less invasive. I say things like, hello, my name is Mitch, or I'm Dr. Lunn, nice to meet you. I use he and him pronouns. Would you mind sharing which pronouns you use, right? And some people, they need that example of which pronouns I use to know what I'm asking, because some people don't know, right? But I think if you're a transgender person, somebody who's not cisgender, a gender minority person, and you signal that you know what pronouns are and that you're asking because you want to be respectful of that person, that goes a long way, right? Mm-hmm. That signals that you have kind of a baseline level of competency that is quite good, and is at least, what the terms are, you can talk about it, and that you're committed to using those pronouns and what name they use, et cetera, throughout the interactions. And we do that not just in healthcare settings, but we do that also in meetings, right? In like research meetings or business meetings or those sorts of things. Yeah. So, I think it's more common for people to see pronouns now on the Zoom name, right? In our COVID world, where people added, on your name that shows in the corner of the Zoom window, or on
Slack,
Slack, mm-hmm. Teams, whatever you use, right? It's in all those places, and the companies are now actually, Zoom has added that feature where you can select your pronouns and they add it for you. So, as a defined field in their software. Yeah, it's So right. I think it's just showing the advancement of society to acknowledging that these are important issues in the healthcare setting and also outside of the healthcare setting.
Sure, because we can impact our colleagues and friends regardless. So
absolutely,
we can actually help their health outcomes by doing that.
You may have noticed, like I included in my email signature in the emails that we were exchanging prior to this, right? It's there, and it's a lot of it's so easy. It's so easy to do because how often do I edit my email signature? Not very often, right? So you kind of set it and forget it, right? And going in there once and adding your pronouns is just a way to signal to your friends, to your family, to your colleagues that you're somebody who, acknowledges that people may use different pronouns, and especially by email, you're not going to know, right? Yeah. And unless you ask them. And so it's kind of a nice way to say, when I'm talking about Mitch, I should use he and him pronouns when talking about him, right?
We'll be right back after the break.
The COVID-19 pandemic showed us how a microscopic virus could upend our lives and how unprepared our society was for it. There's so much more out there that we need to understand, which is why I recommend subscribing to Crooked Media's America Dissected, hosted by former Detroit Health Commissioner Dr. Abdul El Sayed. Each week, Dr. El Sayed sits down with doctors, scientists, culture makers, and policy leaders to ask questions like, how could new genetic discoveries change our relationship with our own genes? How could addiction to social media change our brains? Or how even climate change could make the next major pandemic more likely? To hear discussions on these topics and more, check out America Dissected from Crooked Media. New episodes drop every Tuesday. Listen on Apple Podcasts, Spotify, or wherever you get your podcasts.
So you mentioned Stanford's LGBTQ practice, which is so interesting. How many of these sort of practices are there nationwide, and should we spend more time making more clinics specifically for these communities, or
Sure.
should we spend more time training existing practices? Maybe there's some like sort of accreditation, like we are pride friendly or something.
Right.
So what are your thoughts there?
Yeah. So, boy, do I wish that there were more of them, and boy, do I wish that everybody, was trained and had this kind of cultural competency and cultural humility when interacting with LGBTQ plus people. So, I think the answer is both, yes, and everything else together. We do have. It is much. It is now it's becoming more and more common for places to have LGBTQ affirming practices. And so we think of that especially in academic medicine. This is a kind of an up and coming thing. So, there are LGBTQ health programs at the University of Pennsylvania, at Penn, at Stanford, at University of Kentucky, and many other places across the University of California, San Francisco, and other places. And so it's not just in the big cities, and it's not just in the coasts either. And then, of course, there have always been for decades, and this really was born out of the height of the HIV epidemic, federally qualified health centers and community health centers that serve LGBTQ plus people. They initially spun up to help treat patients living with HIV, and their missions have diversified. And so these are centers like Fenway Health in Boston, Callan Lord Community Health Center in New York, Whitman Walker Health in Washington, D.C., Chase Brixton in Baltimore, Howard Brown in Chicago, the Los Angeles LGBT Center, and others. And so these are healthcare systems that largely exist in larger cities, but have a significant focus on serving LGBTQ plus people. So there are some places like that, and then academic medical centers. But then the question is, what about everybody else, right? The folks, I'm from Bismarck, North Dakota. Originally, there is not a large academic medical center in Bismarck. People get their healthcare from typically one of two healthcare systems that exist in the city, right? And so what about training all of those providers, right?
Sure.
And so I think you're exactly right that there needs to be some training, some accreditation, et cetera, for providers. For healthcare systems, there is the Human Rights Campaign, HRC. People may be familiar with them. They're the famous yellow equal sign bumper stickers that people see around on a blue background. Their foundation runs a program called the Healthcare Equality Index. And the Healthcare Equality Index every year lists healthcare systems and basically ranks them on their LGBTQ competency and friendliness. And there's a whole set of criteria, including non-discrimination policies, trainings for staff, et cetera. And healthcare systems can become leaders, get the designation of a leader by meeting, a certain number of these criteria. And so there are resources for people to, to find out if their local healthcare system, is LGBTQ friendly. In
Sure.
addition, there's an organization called GLAMA, GLMA, which is formerly known as the Gay and Lesbian Medical Association, but now it just goes by the fabulous name of GLAMA. And they have a healthcare provider directory. So they're a resource for people to search by zip code to find providers that are LGBTQ plus friendly. And that's kind of an opt-in for providers. They list themselves, there. And that's one option. And then I think, we would be remiss to, especially in a conversation with you, to not talk about some of the digital options for, especially in the COVID era. It's, spun off a huge amount of telehealth and telemedicine. And so there are now a variety of companies, and Rock Health did a blog on this a little bit ago as well, of the LGBTQ plus health digital space, including the provision of healthcare. So there are several organizations now that provide, sexually transmitted infection testing, include PrEP, so pre-exposure prophylaxis to HIV, a medicine to help prevent HIV, as well as gender-affirming hormone therapy. So actually, for folks who are transitioning their gender and want to have medical transition, that is, taking testosterone for transgender men, taking estrogen for transgender women, to be able to provide that in a telehealth based way. And so you can imagine for folks that live not where there's affirming providers, or live in very rural areas where they need to drive hours. Yeah, exactly. need to drive hours to find a gender affirming provider or somebody who would be able to prescribe that type of therapy. These are really game changers for folks, because it's a way of changing access, when that you can do from the comfort of your home without the fear of that stigma and discrimination that we talked about earlier in the healthcare setting, right? Is the front desk person going to misgender you? Is the valet parker going to misgender you? Is the medical assistant or the nurse going to, make some snide comment about you? Instead, you do it from your computer or your smartphone from your couch. Right, with a company that focuses on that type of therapy with the specific population, makes it a lot easier and safer for a lot of folks.
Easier to hang up too. It's easier to just
yeah. No, I mean, that's one of the great things about the digital space, right? Is if you're being stigmatized or discriminated against, leave. Right, you can just close the window, right? Close the app, right? The locus of control is with the patient. Right, rather than with the provider or the healthcare system. The power dynamic is a little more even in a telehealth setting than the way it is in a typical brick and mortar clinic.
So you mentioned PrEP earlier. Tell us about the history of PrEP and how it's just been a game changer for with its public health impact.
Absolutely, yeah. So PrEP it stands for pre-exposure prophylaxis, and that's a fancy way of saying it's a medication that you take prior to any exposure in order to prevent HIV infection. HIV, I think everybody knows, has been, was, and continues to be, a large problem in society, not just for the LGBT community, but of course, back in the 80s and 90s, that was, a huge component of the population that was affected. And PrEP, has been in the works and for now several, probably approaching 2 decades, which was, the medications used to treat HIV have been multitude, different classes, many different drugs in each class, and there's, a gajillion of them. And what people started to realize was, could we take maybe some of these HIV medications on a daily basis to help prevent HIV infection, given the biology and the viral replication processes that HIV goes through, how it actually infects people. And the short answer is yes, you can. And we now know, there are two oral medications that are both FDA approved for the prevention of HIV. These are medications that, from an FDA indication, are to take every day, and when taken every day, are highly, highly effective. like greater than 99% effective at preventing HIV.
But it is not easy to take something every single day.
Correct. Yeah. So that's the whole thing. That is also you have hit the nail on the head for the challenges, which is that that adherence, as we call it, to medication. Do you take it every day? Is the problem, right? Medications don't work if you don't take them. It turns out, and so just having them in your medicine cabinet doesn't necessarily work.
Doesn't do the trick. No.
Yeah. So, but we do even show pretty high rates of efficacy of, that it works well to prevent HIV, taking, 4 tablets out of per week. So 4 out of 7 days. And of course, as you hit 5 and 6 and 7, those numbers just increase. So those are really great, great medications that I think are really helping to change the landscape. On December 20th, there was a new medication just approved by the FDA, and this is actually a long-acting injectable medication that was shown to be, as efficacious as the oral medications, and it's basically a shot in your butt every 2 months.
Amazing.
And so for folks who have difficulty taking medications every day, with the adherence of an oral medication, that may be a better option for folks, right?
It's the depot of PrEP.
Exactly. Yeah. It's the depot. Yeah. The birth control shot of PrEP.
I think that one's every 4 months, right? Yeah.
No, it's every 2 months. It's every 2 months is what the depot. Yeah. The depot for PrEP will be every 2 months. Yeah. So it's, so I think these are, and I think, a lot of people have made the analogy between PrEP and birth control, right? The pill that you take every day to prevent pregnancy, or the pill that you take every day to prevent HIV, right? And of course now these other versions, right? Of with the other formulations. The challenge is, for folks who are taking medications every day, they might be taking a pill for something else every day. It's easy for folks to add that into their regimen, right? To add another pill, right? Because they just do it. They're already in the routine, right? Of course, the group that is always at risk for HIV the most is the younger folks, right? Kind of the 18 to 24 age range. And most 18 to 24-year-olds don't take medicine every day, right? And so adding a daily pill can be very difficult. And so, they think, I have to buy a pill box, a Monday, Tuesday, Wednesday, Thursday thing. And I'm like, it's a way to remember if you've taken it, right? Because if it's still there, you haven't taken it, right? Because we also run that issue, right? People are like, well, I think I took it. Should I take another dose? Just, right? And that, so there's all those issues that are there. But of course, the largest challenge is, PrEP still does not have the uptake that we hope it would, right? There's continual education that we do in primary care throughout the Stanford system, and that is happening across the country to really make this, better for folks.
What's the cost?
Yeah, so PrEP. So one of the medications is now generic. And PrEP also has what's called an A rating from the United States Preventive Services Task Force. So this is the highest rating that it should be given, to preventive measures. That's the same thing like getting your colonoscopy, right, for colon cancer has an A rating. So PrEP has the strongest evidence for it. And so most insurance companies, and it varies a little bit state by state for commercial insurance, and then of course, or employer-based insurance, but then state provided programs, Medicare, Medicaid, et cetera. I have never encountered an insurance company that doesn't cover PrEP for the generic form. One of the medications is newer, which sometimes is covered by some insurances, and sometimes people have to quote unquote fail the generic version first, have some side effects or other things. But the list price, if you were to buy the brand name tablets without insurance, are incredibly expensive, something like $1,600 to $1,700 a month.
Wow.
So very expensive. And the shot has a list price of double that, basically $3,400, $3,300 a month, because they're making it basically equivalent to 2 months of tablets, right?
Yeah.
So incredibly expensive, but many, the pharmaceutical companies that make them have a variety of assistance programs for people who for some reason are having super high copays or other things. So the whole process is that it's very easy for people to get with little to no out-of-pocket cost, regardless of your insurance coverage. Now is the short answer. So,
Does Medicaid cover it?
Yes.
Yeah.
Yeah.
Okay.
Yeah.
Cool.
Yeah. So there's lots of the goal here is to decrease the barriers to accessing it, right? So, but yeah, it wasn't always that way.
So let's switch gears for a second and talk about LGBTQ youth and their human rights as it comes to being able to access things like STI testing, transitioning, PrEP, etc. But they might not legally be able to do that because they're minors. What is the current state of things, and what needs to be done to ensure that our youth are protected?
Yeah, great question. So, thankfully, all 50 states allow minors, and that age varies a little bit in the state. So some of them it's 12 years and older, some of them it's 14 years and older, some of them it's anybody, regardless of their age, to give consent for STD diagnosis, for testing, without parental consent. So, granted, they have to get to a place that will offer that to them, right? So that's, I think, oftentimes the larger issue. But the laws, do allow, minors to consent to STI services, and it's about 11 states that have this age requirement of either 12 or 14 years old. HIV testing, interestingly, is a whole other story. So they separate sexually transmitted infections out from HIV. And HIV testing, oftentimes, in some states, it's bundled with the STI testing and is included in that. In other states, it requires a separate consent, and that may be at a different age or may not be allowed without parental consent in some states. So it's kind of a hodgepodge of rules. And there's a great CDC webpage that kind of has a chart, a table of what's allowed for minors at which states. And then when you think about HIV prophylaxis, so both PrEP, like we just talked about, or there's another form of HIV prophylaxis called PEP, which is post-exposure prophylaxis. So this is after you've had a potentially encounter with somebody whose HIV status is unknown or who is HIV positive and has a detectable viral load. That is really only allowed in 3 states without parental consent. So you can kind of see it's like a funnel of decreasing access when you go from STI testing to HIV testing and then further down to HIV treatment and even narrower for HIV prevention or prophylaxis. And so you can imagine that, in many cases, LGBT youth may not live in a supportive family environment, right? Even whether they're LGBT or not, many kids don't want to necessarily talk to their parents or guardians about their risk for sexually transmitted infections, right? That might be something that they're not talking about with their, and they might not even be talking about it with their pediatrician or their primary care provider because parents might be in the room sometimes during those visits, or they might just not feel comfortable doing that, right? And so, there are many, and people who live in cities have the ability to go to, oftentimes STI clinics, right, or that are more focused on sexually transmitted infection testing. But again, if you live in a more medium-sized area or in a suburban area or in a rural area, you don't have that opportunity. And some of that can now, again, be done by telemedicine and mailing at-home kits or those sorts of things to be done. But again, there's all the logistics of maintaining privacy and maintaining, privacy of that minor from their parents. Right. Yeah. When the box shows up, you're checking, you're waiting for the mail to come every day, right? And trying to, yeah. So it's challenging. Right? I'm not gonna, it's a challenging situation, right? So, I mean, the good news, I think, is that people have realized that STI testing and eventually HIV testing is important for people, regardless of their age, to be able to be done without another person granting their approval for that, right? So,
okay. But what about gender affirming treatment? Because that is,
yeah,
that's different.
That's totally different, right? So, and that I think is a much narrower, group of, and at Stanford Children's Hospital, we do have a pediatric and adolescent gender clinic, and that typically does involve, parental involvement. Especially when we get to things like hormone therapy or puberty blocking agents, right? So that they don't go through that first puberty and instead go through a puberty that's more aligned with their gender identity. And so those are less accessible without parental involvement. And it typically is because they are oftentimes covered by their parents or guardians' health insurance, right? And so, there are some public systems that, are working to make sure that this is available. So, county health systems have, in many places now have gender affirming care and LGBTQ plus healthcare. And sometimes those services can be accessed without insurance and then can be accessed, in a way that is not needing the parent or guardian's approval, but we do know that gender affirming care especially is life-saving for folks, right? It lowers depression, anxiety, and most importantly, we know that it lowers those mental health outcomes that result in suicide and suicide attempts. And so gender affirming care is one of, for people to be trained on and to do, and can take comfort in that they are, literally saving people's lives by providing that care.
Yeah. And there are now companies like Folks that
Yes.
are offering it digitally because, as we know, there aren't enough clinics across the country
Absolutely,
that
right.
have that expertise. So
So that telemedicine-based approach, again, comfort to do it from your couch, right? Or comfort to do it while you're on a walk away from your parents, right? Or away, out of there. And they found, I think Folks actually doesn't take insurance, and they just have a really rather affordable, relatively speaking, model that allows people to access that way. And I think that there are also, and there's several other companies aside from Folks as well that are offering this, that have, some financial assistance programs also out there, right? Where they'll cover the cost for people who are unable to afford their, I think, monthly fees that they're charging. So there's really lots of ways, and that's again a much safer area where the locus of control is with the patient and not with the healthcare system.
So tell us about the PRIDE study that you lead.
So the PRIDE study is an online longitudinal health study for LGBT adults. So you do have to be 18 or older. I co-direct this study with my close and dear friend and colleague, Dr. Juno Obedin-Maliver, who's an obstetrician and gynecologist also at Stanford. We met in med school at Stanford in 2005. So we've been working together for the past 16 years or so, doing LGBTQ plus related health research. And the PRIDE study really has an overarching goal to look at how being a sexual or gender minority or being LGBTQ plus person impacts your physical, mental, and social health. And we do this via a community engaged approach. And so many healthcare studies that people have either heard about or participated in are oftentimes conceived either by pharmaceutical companies or conceived by professors, like me and academics, and they don't take the community input and the community experiences necessarily into their design and approach. And so instead, who am I to know what an experience is like for an African-American transgender person living in rural Arkansas, right? Who am I to know what life is like as a cisgender lesbian woman living in Minneapolis, Minnesota? And so instead, we've taken an approach where we engage participants and LGBTQ plus people at every stage of the research process. And this includes from question design and study design all the way to recruitment, obviously participating in the research, in the analysis and interpretation, and importantly, how those results get disseminated back to communities. Many research... What's that?
This is so interesting. So they're not just your subjects.
No,
they're
no.
your research partners.
Exactly. This is a partnership-based model, and we move it more from a transactional approach, do this study for me, do this thing for me, to a transformational approach. How can we work on this together to change healthcare or change aspects? And, many research studies, as we like to say, live and die in medical journals. They never reach the populations, one, who participated in the study, and two, the populations that we hope that will benefit from the results, right? And so our process is, before the second we have a research paper published, we have a community-friendly summary of findings already available for people to read. So this, if you've ever looked at a scientific paper from a medical journal, oftentimes you have to pay for it. Oftentimes in an insane amount, like $50, and you get like 30 days of access or something like that. And then you get it, and it's written in the language that doctors and scientists speak, which may not be the language that you speak or understand. And so we create a more community-friendly version of that. We send that the first people who learn about our study results are our study participants. They're not Stanford. They're not our funders. They're not our colleagues in LGBT health research. Literally the first people that get an announcement are our participants.
Yep. And are these observational studies?
Yes. Yeah. So right now, the PRIDE study is observational. So we have over 23,000 adults from across the country that have enrolled in the PRIDE study. They participate primarily via our annual questionnaire, which is rather lengthy. It takes about 45 minutes to an hour to complete. You don't have to do it all at one time. You can do, start and stop at your convenience. And that really gives us, asks a lot of questions, some of them rather sensitive about people's lives, both physical, mental, and social health. And then additionally, we throughout the course of the year, we release other studies that are shorter in length, anywhere from usually 10 to 20 minutes, that focus more in depth on a particular topic. So we released one yesterday about people's experiences with mental health treatment and counseling, for example. We're having ones that will probably be released next week, or if at the very latest, the week after that, there'll be a new survey to discuss COVID. We've launched previous ones about COVID, but getting the current impact and people's, vaccination interests and beliefs and many other aspects of COVID. And another one about how COVID has impacted family building for LGBT people. Has it influenced whether or not you were going to go through surrogacy or IVF or sperm donation or egg donation, et cetera, right? Has it delayed your plans, changed your plans, affected your plans in some way? And how has also COVID for people who are pregnant, how has that influence their prenatal care, their anxiety, all these other things that, of course, are going on, fears of getting COVID themselves, fear of COVID harming their babies, all these options, these things that, of course, you've probably heard over the past years, So
I'm excited to see that study. That's interesting.
So this is kind of the way the PRIDE study works. We have this big annual questionnaire that, is once a year, releases every June or so, is open. We try to kind of do a PRIDE month release, and is open for 11 to 11 and a half months or so, and then these annual questionnaires that come at various times that are shorter. I'm sorry, these in-depth questionnaires that are shorter, that are on particular topics. And then we are starting surveys as one data type. We're now in the process of kind of expanding our interests to look at some other data types. So we have a study launching pretty soon, where we'll actually be collecting blood specimens from 600 people as a start. People can go to their local Quest Diagnostics. These are freestanding labs that exist all across the country to get a couple tubes of blood drawn, which will be actually sent to the Stanford Biobank for some different studies that we have planned there. So we're looking to move into various data types, not just surveys, but also biospecimens and other things in the future.
Yeah. Well, if anyone listening wants to learn more about Dr. Lunn's work and participate, you could visit pridestudy.org or follow them on Twitter at The Pride Study. Dr. Lunn, thank you so much for this conversation today. I learned quite a bit and have some new perspectives, so I really appreciate you.
Thank you so much for having me. It's been a delight to speak with you today, and I hope that this was educational for your listeners, and happy to have them reach out to me or to any of the Pride Study folks if they have any questions or other things that they would like more information about.
Thanks for listening to this episode of The Heart of Healthcare. If you like the show, be sure to subscribe, leave a review on Apple Podcasts, follow us on social, and tell all your friends to listen. The Heart of Healthcare is a product of Offscript Health. We are a healthcare engagement company built for patients and caregivers by patients and caregivers. Our executive producers are Matthew Zachary and Andrew McDowell. Our senior producer is Brianna Seeley. Our intern is Antonella Sterniolo. Our host is Hallie Tecco. It is recorded, mixed, and edited by Brianna Seeley. For advertising and media inquiries, email media@offscript.com. That's media@offscript.com. For more information, visit offscript.com.